I want to welcome to the stage for our morning keynote a panel on leadership in healthcare by 4 of the most amazing people that are working in this space, some of whom you know, some others you may not, but let's welcome them all to the stage. Dr. Demetria Malloy from Anthem, Dr. Tanya Dansky from Blueshield, Promise Health Plan, Sarah Sommer from the CEO of Ascent, and the T is right there, that's good, and Lisa Chan-Sawin, CEO of Transform Health. Let's give them a round of applause. Come on up, ladies. So we had to be able to reach you, and you had to be able to put up with us. Thank you. Thank you.
Thank you.
Yeah. Thank you, Lisa. Thank you, Demetria. And they're all like, so what are we going to talk about? And I was like, so Sarah, I won't call you Stacy or Summer, but Sarah, we joked beforehand that I might mess up their names. But Sarah, thank you for doing this. Let me just sort of ask you with the softball question first, because you've had a number of hats in healthcare and health policy, and recently have taken over the CEO position of a physician service organization run out of CMA, the California Medical Association. What are the things that you are spending your mental energy on vis-a-vis the external world? I know you're spending a lot of time internally, but in terms of policy, in terms of market activity, where are you focusing your attention?
So I would say, well, number one, we were promised Bloody Marys, so I feel a little
Those
bit
come
excited.
later. Those come later.
What I'm spending a lot of time on is really thinking about alignment, because I think we are hitting, you mentioned this in your presentation, but we're kind of hitting a socioeconomic tipping point, and we have moved fairly slowly in healthcare, but we are starting to move really quickly, and I'm very worried that we're going to end up running in different directions really fast and not aligning. And having come from a health plan, and before that the government, and now being on the physician side, I think it's really important that we have consistent standard requirements for physicians so that they can actually spend their energy on what they do best, which is being with the patient. So I am worried that if we aren't thoughtful and if we don't work together in new and different ways, we're going to end up with a whole host of requirements, none of which are coordinated, none of which might make sense, and none of which work for physicians and ultimately patients, which is who we are ultimately working for. So I think that's what keeps me up at night.
So alignment, Tanya, that is one of these things like value-based contracting that's easier said than done. And it does seem like perhaps frustratingly, but maybe rightfully, that the bars by which we are measuring ourselves in healthcare consistently change by regulators. What do you make of the sort of state of physician plan alignment as a physician executive at a plan?
So as a physician executive at a plan who has also worked in the hospital sector and the IPA side here in California, for me it was a natural transition, because who better to help that voice of physicians than a physician who can work from within a health plan. So I think the main thing to really focus on is that health insurance companies really are related to health care. And I think as that physician leader, I try to always give voice, for example, to member stories or patient stories. I've instituted that we can't have any committee meetings, at least that I'm a part of, if we don't start with a member story, to remember what that interaction is in the healthcare world. And I make sure that we share stories both of when this works and when it doesn't. Because there are so many times in healthcare where things fall between the cracks, and it's not how anyone intended for the system to work. But we have to keep being that voice of our patients and our members and our family and our friends and everyone who's trying to navigate the healthcare system, and just keep working hard at it and chipping away to figure out how to do this better.
Demetria, that's Tanya's story, but I'm sure it's your story as well in terms of keeping members at the center of the work you do at Anthem. But let me ask this sort of question about the culture within healthcare, which is, I would characterize the culture of most of healthcare as a care-oriented culture, often a female-led culture. But as you move up the executive ladder, that shifts at some point to become more of a a male-dominated culture, sometimes less oriented towards care and more oriented towards finance or other things of that nature. Do you find it, as a physician leader at a health plan, do you find it tricky to infuse, I guess I want to ask about that sort of member centricity and whether you have to elevate that like Tanya does, but I also want to just ask, what's it like being, a woman in a female-dominated culture except for at the top?
Yeah, it is an interesting position. I think sometimes I don't think of it as much when I'm in the room, but sometimes you can't help but notice that you may be like the only female, or there's two and there's like 10 other guys and sitting around the table. I think in general, I try to make sure as well that all of the other women that do work in this area, in healthcare, because there are a lot, like you were stating, that really run the workforce in healthcare, do get their ideas heard, have their voice heard, and I encourage them to actually push that to the forefront so that they can actually show their complete value add and get that position at the table as well, because that's the thing that actually makes all of our programs, all of our alignment, as Sarah was referring to, work better when we have that representation across the board. So I just try to work to encourage that and facilitate that.
Yeah. You want to, what is that? Well, I was going to ask you a little more. I was going to ask you a question I should ask over the Bloody Mary. Let me set that aside, and we'll wait for the Bloody Mary later.
I'll be here all day.
Lisa, on the consulting side, you've been able to work both in California and across a number of other states. How does this alignment and cultural piece play out in states and systems that really need to change their culture, have to adopt new alignment across different silos? What are some of the lessons about cultural leadership that you see in the organizational transformation space, either in California or other states?
Oh, that's a great question. It's absolutely critical. I mean, when you think about the fact that, women make 80% of the buying decisions and decisions to access care in America, it's really critical to have that female voice and an understanding of what the consumer is looking for. And when I look at transformation efforts, what I'm seeing across the nation is more and more often women are stepping up, but they're stepping up from like lower level roles, mid-level roles. It's, as other panelists have mentioned, we're seeing a really small number of women at the top. I mean, Oliver Wyman did a fantastic report that looked at this, and in healthcare, only 30% of the C-suite are women, and that's even smaller when you get into the CEO positions. Only 13% of healthcare companies have women as their CEO, and that's a complete mismatch and imbalance with what the consumer looks like and what the consumer is thinking about.
Yeah.
And so when we think about how to transform healthcare, and we think about social determinants extending beyond the walls of clinics and hospitals and thinking about broader population health, it's really critical to engage women, be able to capture their voice, and really think about how to provide services in a way that is family friendly, that actually meets their needs, because they're the decision makers at the end of the day.
Yeah. So, Demetria, what does that look like when you've got a system of executive leadership that generally does not reflect the Medi-Cal population that they care for at a Medicaid plan, like the plan in Anthem that you lead? How do folks connected to that care experience, like some of the clinicians, how do you infuse that kind of perspective and voice into a culture that is generally well removed by income, often by gender, and often by education, and often geographically as well, from the Medicaid community?
I do have to give a special shout out. We actually do have a female CEO at Anthem, so that has actually helped, I think, in some of this culture shift. There are a few leaders at the top, actually, that are women and even have come underneath Gail Boudreau, our CEO. So I do think actually placing a woman at the top does lead to some of that. She actually facilitates getting more of that voice in as well, as women leaders often do. I think with translating to the member population that we serve at the Medicaid plan that I work for, I really try to as well. I'm one of the sort of external facing pieces and the providers that go out into the community. So I try to talk to my peers who are really there at the point of care every day to get their opinions on things and what they need, what are their pain points, what's going on that we really can help with at the level of the plan to facilitate that provider-patient relationship, because that's what I certainly hold sacred and always bring to the table as something at the forefront. And we certainly also go into the community and actually have, community advisory committees where we try to hear from the advocacy groups, from the members themselves as well. So I think there's definitely an intentional effort to try and get out there and get those voices and hear the actual words from the people all in the field every day. We certainly could do a better job of that, but I think that that's definitely intentional, particularly for the Medicaid plan.
Yeah. Sarah, let me ask you about sort of culture instead of sort of up within an executive hierarchy across silos, regardless of the executive level. You've been in a lot of different silos, right? With you're CEO of a physician organization now, physician service organization. You were at a plan, Blueshield. Are we getting better than 5 or 10 years ago about working across our silos? Is there more of a culture to support it? Or do you find that it's still really about individual effort and individual initiative?
It's a great question. I actually think it depends, which is like the very lawyer answer in me. It depends where you are, but I would say as an industry, we are getting better. So I think people need to invest in relationships. I think that's a learned skill that we really need to value, both within their internal organization, but really in particular across organizations, because you need to understand the other parts of the industry. And the only real way you can is by getting to know the people who are working in that industry, who are part of the community that is being served, who are like making the decisions across the spectrum, across the silos. And so I think that there is work to be done to put a value on investing in relationships, investing in going out there and meeting people across the industry and finding new ways to work together. It takes a lot of effort, and I think people get bogged down in the day-to-day and don't actually make that effort. But we are seeing a shift, certainly in California, and I've been in California 6 years now. I think because we are seeing such a pressure from the federal side, and because the ACA is under attack for the last, 3 years now? It feels like 15. I think people are thinking about how we can work together differently so that we can actually transform healthcare, because we have to. Otherwise, if we don't disrupt, we will be disrupted.
Yeah. Tanya, tell us about that sort of multi-silo work you guys are doing with LA Care and your Family Resource Center strategy.
Yeah, I was wanting to echo Sarah's comments and also open up the tent, to use one of Wells Shoemaker's terms, under the big tent. So the idea of providers, health plans, more traditional healthcare silos, getting to know each other and building those relationships. But something that we're doing with, putting these resource centers and expanding the resource centers out across Los Angeles is listening to lots more stakeholder voices in the big world of healthcare. So not just to use the word social determinants, but to actually dig into it and figure out who are all those community stakeholders that we need, whether it's someone who runs a housing nonprofit, someone who has the leader of a local food pantry, and even to go beyond that and try to think of who are our faith-based communities that are in that region, who are the people, to your point, of the women that are leading these families oftentimes and making healthcare decisions, who are their trusted advisors, who are they looking at, and really allow the resource centers to be a place where it's one-stop shopping. Whatever you need, you can come in and we'll have the tools, or at least the ways, in a human way, culturally appropriate, in whatever language they need, to be able to connect people up to what they need.
So Lisa, on social determinants, you've spent a lot of time thinking about that here in California and in other states. California, here sometimes we like to think we are progressive, and we are, but perhaps not as progressive as we'd like to be. And social determinants is a topic that we haven't yet fully figured out how to address and integrate into a business model. What does that conversation look like in 2020 as the waiver unfolds? And what are the conversations we should be having related to the waiver and the next procurement related to social determinants?
I think that conversation has already started, where we in healthcare really have acknowledged and embraced the need to address social determinants. But that means having a slightly different workforce, different networks, having some unique partners, right? Like, how do you engage with housing or food pantries and have them in your network as a health plan? Like, that's a very different conversation. I think that as we move forward in this waiver, there's going to be a lot of conversations around in lieu of services. What are those critical services that we could be paying for that keep people healthy in the community? Really moving away from a disease care, sick care model to a population health, a community health model really requires us to think differently. And I think a key part of that is also rethinking our healthcare workforce. I want to give a shout out to Maria Limos, who's been working hard and is one of the founders of a national association for community health workers. We need to think about how we use technology, how the workforce has to be reshaped so that we can have those extenders into the community. And when we think about how to fund that, that means very different types of contracting models, different types of partners on the ground. And even within my firm, I founded Transform Health because what I was seeing amongst my peers were women who really struggled to advance because they were making personal life choices around family, around being caretakers, and it really pushed me to rethink the way that I staff and that I hire. How do I create that flexibility so that I retain really good staff that can evolve along with my company, and that my contracting model is evolving as their lives unfold. I mean, women need different things at different stages in their lives, and so I think that's a key part of our challenge. The community health workers, paraprofessionals, rethinking all the way from the frontline staff all the way to the C-suite is necessary in healthcare if we're really going to embed and create some infrastructural changes.
Tanya, how do you think about that piece internally when you're hiring? How does gender and lived experience play into Blueshield Promise Health Plan and your hiring practices when you're trying to build a team that can work across silos, that can reflect the lived experience of your Medi-Cal members? How do you approach that so that you can have a unique team to meet those needs?
Thank you, DJ, for a hard question. I know how I do it. I'm not sure exactly how to explain it. So maybe I'll go up a level, which is Blueshield as an organization has a very strong culture of looking at truly creating diversity and supporting diversity within the company. So something that we have is these employee resource groups. So whether it's our African American employees, and all of these groups are include allies or employees who may not be part of that group but want to support and learn. And so whether it's LGBT or our Asian Pacific employee network. We have one for Operation Vet, which is our veterans community, which really is a culture in and of itself that we support. Again, super strong in San Diego, for example, to encourage that lived experience and that rich background to help inform how we transform healthcare. Because we can't transform it just for a certain subset of Californians. It needs to be for all Californians. So I think, as we're building these teams, as I've been hiring community members to join the health plan, it has been a struggle for me as I've, had deep conversations with Maria in the past about we need that community connection to be authentic. We need it to be someone who speaks the same language, grew up in the same circumstances, really understands the member or the patient's background. But then again, we also, as a health plan, are learning how to do this. just to be transparent. And I may understand it from working in a FQHC in the past, but a health plan may not quite understand this. And so how do you create roles, at least within the health plan, to start this conversation so that we can move forward to the next level where we can truly partner with an outside organization that may be a more authentic employer for the promotoras and community health workers?
You know, I appreciate the authenticity. It's one of the many reasons we invited you up here, Tanya. I think the fact of the matter is health plans, particularly in the Medi-Cal, Medicaid space, they have a different population now post-2014. And with increased flexibility, they're able to do different sorts of things. And they're now required to do different sorts of things under waiver and statute directives. Demetria, let me ask you, where would you say Anthem is on this imaginary spectrum? Like, what are the sort of interesting nuggets that you all have learned post-2014 as a plan and now incorporated and are sort of generally accepted? And what are the sort of things that you're still trying to figure out in terms of supporting your members and working across silos at community level?
I mean, I think we learned that there was a lot to learn, right? And actually that there were a lot of people, organizations in the community that were doing a lot of the work. So I think even in last couple of years, I would say especially, that we've made an intentional effort, sort of to what Tanya was referring to partner with, identify and sort of look at the plan's role as identifying and vetting some of those community-based organizations for their impact, for their reach, for their knowledge base, and then making partnerships. I think, what Lisa was saying is the challenge is, how do you make some of those partnerships? What do they look like structurally, and how do you properly compensate people for what they are adding, what they are bringing, their skill sets? Because the question sort of is, do you hire in people to the health plan, or do you really try to partner with the existing organization that's been there, been standing there, is trusted in the community? I sort of lean towards the latter, but I think there are complicated ways of trying to figure out how to do financial relationships or any particular compensation around that. And I think that's where the work, is tougher, but is being done, particularly at Anthem, and I see it across all the health plans as well. And so that's where the continuing work is to be done. But I think we've learned that there are other subject matter experts for sure out there, and that the job is for us to leverage that, mobilize that, make that work for our members.
Yeah. Sarah, let me ask you, within the context of the tyranny of the right now, meaning we might have big ideas about what we want to do with our lives or our career or even our day, and sometimes we've got to respond to whatever it is that's burning. So this is an unsexy question with maybe an unsexy answer, but what are the biggest challenges, the biggest problems that you're facing? When you go back to your desk and you're like, okay, I got to figure out how to do this thing. What is that thing or those things, even if they're not terribly headline things, but they're real and authentic? What's on that list?
So for me personally, and probably for CMA, it's about really being able to understand the physician community, which is different coming from a health plan where you have members, but for us, our membership is physicians, and they're all over. So they're practicing in all sorts of modalities, they're practicing in all sorts of geographies, and for me in particular with Ascend Physician Services, we're trying to figure out how to support independent physicians, and they are all over the state, and California is big, so how are we identifying their needs? How are we supporting them? As it comes to women, we have a big focus right now on workforce and on wellness. And female physicians are burning out at twice the rates of men. Female physicians are 2 to 4 times more likely to be depressed or commit suicide. In terms of workforce, we all know that people do better, patients do better when they have a doctor that looks like them, that sounds like them, that they can relate to. And so we're focusing a lot on access. So for me, it's how we're actually hearing the voice of the physicians, of the practices, of the communities, which has meant for me this summer has been a lot of road trips across the state to Fresno, to Bakersfield, to Riverside, all the way down to Imperial County, because that's where our physicians and practices are, and whatever we build should be building for them, because otherwise they're going to be forced into choices that they otherwise would not, or they're going to not even enter the practice or leave the practice. And we're seeing that over and over and over again. And so it's really imperative for us. And I feel like there's a lot of urgency around this, that we understand what their needs are and that we can address and support them so that they feel like they can, again, focus on practicing, feel like it is professionally and personally sustainable and rewarding, which is what they went to med school to do.
Let me ask you another sort of follow-up to that, Sarah. So many physicians feel like they're on the sort of whatever, the rat wheel, they're in the rat race, just, trying to hit more patients so that they can generate the revenue to uphold the entire infrastructure, and they are haggard and harried and tired, and that's in part because of the fee-for-service model, right? They've become an hourly employee by a different model, so to speak. How do you find, I know you've only been there a few months, but speak to how CMA is finding the willingness of doctors to fundamentally change the way they work. Maybe instead of being the primary caregiver, being the team of the team leader with a number of mid-level providers, or engaging in a telehealth model that might be really fundamentally different from both a regulatory model and a caregiving model, but which might be different and better for their balance and work-life balance. How open are they in your perception?
So I would say a few things. I think they are really open to the vision. I think everyone is open to where the vision is, moving from volume to value, paying for care differently, paying for care teams. I think there is a healthy and founded dose of skepticism. So I think they are seeing a lot of PTSD from meaningful use and having to implement EMRs and then not having any funding or support to have ongoing implementation, and none of them work. And it's kind of, they see the vision. What they're afraid of is investing in the here and now and having that change over time or losing support. And I think when we talk about it at the systems level, we forget just how much work it is, both from taking time away from patients, but also in the business of their practice, to actually invest in that. And so I think they're super on board with the vision. Everyone is excited. I think what they really want is to know that if they invest in meeting value-based care, if they invest in population health, is that where the direction is going to stay? And are all the plans going to get on board? Or are they going to have one requirement for Blueshield, one for Anthem, and 17 more for the other plans that they contract with? So enthusiasm for sure, skepticism as well.
Demetria, how do you sort of navigate the two real worlds in the provider space, one which is an eagerness to do better and exhaustion? If you're coming to them as a physician executive representing a plan, you're like, hey, we've got a really new sort of model for you, and they hear, hey, we've got a lot more work for you.
Exactly.
How do you navigate that?
Yeah, I think I acknowledge that. I understand that that's their reaction, and that's perfectly normal and natural, right? And I think when I'm sort of navigating this internally at Anthem, I try to bring that voice to the table. So, I'm biased. I really think you should have clinical executives at the table for all these different business decisions, because we will bring up things that you never would have thought of, and it really, affects the feasibility of the plan and how it actually being implemented. If the doctors don't go for it, it's not going to go well, and that translates down to their patients, and that's who we're ultimately trying to serve and make sure things work smoothly for. So you've got to go through that. They're the patient's trusted advisor, which is often their provider, right? They might not like anything else about the healthcare system, but they like their doctor. And so if you can sort of make them happy, get them on board by understanding their pain points, their issues, and really trying to work with that, I think then it goes, better across all the stakeholders, because the provider's on board, and then the patient's likely on board. Yeah.
So Lisa, in a post-2020 world where we will likely have a new waiver of some sort, and not to get too technical, but after you rebase the budget and you can no longer fund future programs based on previously earned savings, real or projected otherwise. And money goes away for some of these programs that we've been building infrastructure for. How do we navigate that collectively in 2021 moving forward, where there just seems, when we're all so exhausted from doing the work of this waiver and all of that stuff, and there were plenty of carrots there. If we move into a world where there maybe are fewer carrots, Do we need more sticks while we're all exhausted? What do you think? What does that next world look like?
You know, you always have to have a mix of carrots and sticks, but I think what we have to fundamentally realize is our current delivery system was built for a fee-for-service model. And if we really want to move forward with value-based care, our underlying delivery system infrastructure has to change. And that comes from the people, the technology, the way we share data. All of it has to come together in a very different way. And that does not happen overnight without resources. I think it is a mistake to continue to fund the innovation and the transformation that is needed, because ultimately it is hard work. You have to carve and create time for community members, for providers, for plans to come together in a different way and create a different delivery system together if we're really going to have value-based care. And that means that takes away from something else. Time is a resource and is very valuable, so we should recognize that. And with whatever shape the next waiver comes in, I'm hopeful that we will recognize the need to continue to invest in the delivery system and invest in these changes, because we can't continue on with the same underlying fee-for-service delivery system. We will never get the gains, the efficiencies that we really need to achieve as a country and within healthcare.
Yeah. So I want to ask each of you a form of this last question as we wrap things up. And Lisa, I'll start with you. What advice or counsel would you give to folks in the audience about trying to build in different lived experience to their organizational leadership team? Lisa, you go first.
I think we have just begun. I think we are now making conscious decisions about staffing choices, about who we engage. It's not always a build internal, it's about the relationships and the partnerships in the community. Healthcare is local, and what that means is nobody can live in their own silo. And it's so fascinating that, as we think about social determinants, we're really trying to figure out how to engage in a social model when healthcare has been so firmly grounded in a clinical model. And it's a fascinating dichotomy when we think about the substance use disorder and the ODS waiver and why we're trying to move away from a social model to a clinical model. I think we need to probably do both. But we have to be conscious about who's at the table and who do they represent, and make sure that the workforce represents those who we're trying to serve.
Yeah. Sarah, similar question. What advice would you give folks about trying to build those relationships external to their silo or adjacent or outside of their silo?
I think listening. I think it's totally undervalued and kind of glossed over, but we can have a lot of conversations, but if we're not actually listening to our stakeholders, to our partners, if we're not actually trying to understand where they're coming from, because oftentimes we hear, but until you actually go and meet them where they are, go to the communities that they serve, actually have that conversation and try and hear what they're saying and take it back and into your decision-making process. So I guess it's a combination of one, listening, but then also making decisions based off of that. So making use of the information that you've gathered and actually bringing that into your organization and into your decision making.
Demetria, what advice would you give to folks trying to navigate this time of policy and political uncertainty? What advice would you give them about leading their organizations where the ground seems always on the precipice of moving one way or the other?
I like a combination of what Lisa and Sarah said. I think I was thinking of this question, and I thought my answer would be what Sarah was saying, which was listen. So I think you have to get what other people's points of view and perspectives are on it, and then I think that's where you can sort of build a bridge and actually find a win-win or a common ground, somewhere to start. Because I think then once you find that and you get a win for all parties in one area and something that everyone cares about, whatever it is across the healthcare spectrum, then you can actually move to the next step, right? And so the other thing I think I would add is that, like, educate. I actually think that a role for the health plan to do is to actually go out into the community and say, here's what's coming down from the state. Here's what they're thinking about. Here's what's probably going to be coming down the pipeline for you. Let's talk about it now and see, like, what can we do to set this up so that when it actually comes down sort of in some written edict somewhere, that we can actually, you know, adhere to it, actually work together to actually make sure that it is going forward. And so I think listening and educating sort of fosters those conversations that lead to good implementation.
Yeah, good. Tanya, last question. As you know, our audience is pretty senior across a diversity of silos. When they are thinking about building their leadership team or building silos or the policy world and how that might shift, and they're up at 1 in the morning and they're worried and they're trying to think about their P&L and keeping their team and meeting the needs of their community, what should their North Star be? What should reorient and recenter them as they go back to work the next day and continue to do the hard work of leadership?
So I think I would really go back to, we're all in this healthcare game together, even if we work in particular silos today, maybe tomorrow we'll be in a different silo, and we need to really be intentional about not only listening and educating, but being very thoughtful about the language that we use. Whether we're at a policy and we're talking about, you know, those physicians, those primary care doctors, they're X, Y, and Z, to think about the fact that they went into this for the right reasons. They want to help people and take care of patients. And what can we do, to your point, Sarah, to kind of get out of their way, but to also help them be more successful? Because there's a lot of things that I can say as a physician I didn't learn in medical school. I didn't understand the difference between, for example, in learning, you know, Western medicine, physical health, medical school, that I was going to be at a table if I'm trying to help integrate mental health and substance use into a whole person approach to care, that we would stumble at the beginning of the conversation just on who we're talking about. So I, as a doctor, might call someone a patient. When I'm in my health plan role, I call them a member. Substance use community is going to call them a consumer or a client. Mental health may call something different, and we're going to be judging each other on what we even call the patient in the middle, the person. See, I go to patient. I'm a doctor, sorry. But just to really think about that there is that person in the middle of this, and that person, not to be too cheesy, could be our grandma or our sister or our child or our neighbor, and we want them to get the care that they deserve, and that's everyone in our community.
Tanya Dansky, Chief Medical Officer at Blueshield Promise Health Plan, Sarah Summer, CEO at Ascent Health, Demetria Malloy, Senior Medical Director at Anthem Blue Cross, and Lisa Chan-Sawin, CEO at Transform Health. Let's give them a round of applause. Thank you.